I'm also in a panelist view here, but what we see here are your slides, which are 80% of the screen, and then there's a little thumbnail of you.
Okay, so okay, 80% and a thumbnail of me.
Yeah, so it's enough to see that you're who's talking, and then also your slides.
Okay, so
Anyway, thanks for coming. It's nice to meet you virtually. I'm Eleanor Tanno.
same here. Thank you. Nice to finally meet you. I checked on some of the older videos to get a handle on how this works, but
okay. So yeah, so what basically, people are joining, so we'll give people a few minutes, and then you can give your presentation, and then people can submit questions to the chat or the QA section, which it's really hard for you from your view to see it. So that's part of the reason that I'm here, is to read questions out loud.
Mm-hmm.
Sometimes I'll interrupt you with a question if I think it's pertinent to the thing you're talking about, but a lot of times you just wait till the end, because I think a lot of times it's hard to, but it's also your preference. If you prefer to be interrupted, then I can do that. But if you'd rather just kind of wait till the end and then we can have a little bit more of a discussion, that works too.
Yeah, I think at the end is fine, because I only have 20 slides or 19 slides. I don't think it'll go the full 35 minutes.
Oh yeah, no, that's great.
And I kept it kind of light, because my understanding was that it's mostly patients, right?
It's all patient. I mean, occasionally some of our doctors join in, but it's really there might be 2 doctors on the call, and then the rest of them are the patients.
Okay. I don't know if you looked at the slide, so it's fairly light, and I'm really just focusing on iron deficiency and B12 at the end.
Oh, good.
It's so common, and I think for patients that's good to kind of really just focus on.
Yeah.
So I think at the end, then I would rather kind of move through the slides and then
okay.
questions.
Yeah, I think that usually works better, because it's like less jumping in and out. But okay. And then when you say name, is the H completely silent?
When I say what? Oh, my last name?
Yeah.
Yeah, it's there's a little bit of an H, so it's actually pronounced Mahmood. So it's like it's a very soft H, though. And let's say in English, it's kind of difficult to do that if you're not used to saying it. So I commonly, for patients, I say Mahmood.
Okay.
Or just Mahmood, like a very quick Mahmood.
Yeah. Okay. Got it. Okay. Yeah. Because I wasn't sure if I was saying it right. All right. Well, let's give people a few more minutes, another minute or 2 to join, and then I'll make some announcements, and then we can get started.
Okay.
And all your introduction that you had sent over. And obviously, you're going to have to tell people about the hobbies, because I feel like. Oh yeah, I told you your colleagues, like Dr. O'Connor does trapeze, and and then last week Dr. Patel said he does boxing. That was something else interesting.
Yeah, well, we can't really compete against Shannon. She's on her own different level there.
I know, she said she has her kids doing it too.
Yeah, I saw her video, so I was a little bit surprised about that too. So okay, well,
I know.
They got good genes. The kids have good genes in terms of athletics, so that doesn't surprise me.
All right. Well, let me go ahead and give some announcements to people. It looks like we have probably. I don't want to hold it for people who are on time. I like to reward them for being on time. So just quickly, for those of you guys who are joining today, we have an outside speaker. I'll introduce him in a moment. I'm Dr. Tanno. I'm doing these webinars, as most of you guys know. And I just want to say, today is a talk on anemia. And I think as far as these webinars go, I know I said something about this last time. I think we're going to take a little hiatus for some time. Our office is making plans to reopen the week of July 13th to some visits. So I think a lot of the doctors are going to be busy doing inpatient or patient care. So I think there might be there's changes there. Also, I will be on vacation next week, so that makes it complicated to coordinate these from far. So I think what's going to happen is we'll take a break next week from webinars, and then the week after, depending on how things are going in the office, we may move to a once a week schedule, either Fridays or Mondays. Actually, if you guys want to submit to the chat, if you prefer Fridays or Mondays, that might be helpful. But like I said, this is evolving and we have to kind of figure out with our protocols and COVID what exactly is happening. So for everyone who's been tuning in, it's wonderful to have you here. You know, we've loved doing these. It's interactive, it's fun, it keeps people engaged. But I think we are reaching a point where this will not be a forever series at this point. I just want to let you guys know that there is an email that goes out this week that says, you know, no lectures for the next 2 weeks, don't panic, but that's sort of the logic behind it. So it looks like we have about 25 people, so we have a good number of people on the call. Today we have an outside speaker, Dr. Mahmood. He is from Maryland Oncology and Hematology. He is, for those of you who saw Dr. O'Connor's talk a few weeks ago on genetics and cancer, and then I think it was last week, Dr. Patil talked about, he's a colorectal surgeon from their center, talked about some bottom issues, as he called them, so rectal issues. This talk is a third one from the same practice, so we are so grateful that they're joining us from outside to you know, add a little diversity to the things that we are talking about. So Dr. Mahmood is, he can tell you more about his history at the practice, but he went to the University of Miami for medical school. He did his internal residency at Boston University, and then he did a fellowship, which is, it's another three-year fellowship. How many years of fellowship?
Correct, 3 years. Yeah.
Additional 3 years of fellowship at the University of Maryland in Baltimore, where I went to medical school. And so he's done a lot of school. And in his free time, he plays tennis, badminton, and squash. He travels with his family. And so, as I was joking around before, for those of you who heard, their practice is a very athletic practice. So, I guess the badminton and the squash fits in with the boxing and the trapeze. It's impressive. But I'll let you take it away. He's going to talk to us. He said he's about 20 slides, and then we'll take questions at the end. So please submit them. It's always more fun if there's questions from the audience.
Okay. Welcome, everybody. It's a pleasure to be here. And yeah, in terms of my, let's say, hobbies, I like athletics, but I can't compete with Dr. O'Connor. You know, like I said, she's on a different level. But yeah, you know, athletics are good, but right now with the COVID, you know, everyone's stuck at home, and so am I. So really, my life has revolved around my two young boys. I have a 3.5-year-old and a 9-month-old. So between my wife and I, we're quite busy just with that. So, but again, it's a pleasure to be here. So the topic that I actually wanted to talk about was really the basic subject of anemia. It's a really large subject, but really wanted to focus on the myths, the misconceptions of anemia, how to recognize it, you know, common symptoms, and then actually management for a couple unique specific topics for specifically iron deficiency, B12 deficiency anemia, and really touching on the topic of anemia in the elderly, really over the age of 65, what it could mean, and just how we think about that. And it shouldn't be that long of a talk, and I'm definitely open to questions. I really want to kind of get through the information, talk about things, and then answer as many questions as I can. Again, the outline, just going over some definitions. I'll talk about the importance of recognizing anemia, some common myths involved with that, causes of anemia, and then focusing on B12 deficiency as well as iron deficiency, because it's really so common. Okay, so what is anemia? Anemia is, as a strict definition, is the absolute decrease in hemoglobin, hematocrit, or the actual red blood cell count. And many of these are now all automated on a CBC machine, so they're really calculated from each other. So it's really, you get to pick. Some doctors will focus on hematocrit. When they talk to you about anemia, other doctors will focus on hemoglobin. And it's really interchangeable. And how I view it is really just focusing on the hemoglobin. When I say someone, or I see someone who's anemic, it's really because their hemoglobin is low. What is hemoglobin? Hemoglobin is a protein in the red blood cell. It transports oxygen throughout the body. Iron is a key component of that chemical, of the molecule of hemoglobin. So that's why that's a crucial element. or nutrient. And what are some definitions? So for men, hemoglobin should be greater than 14. If it's really less than 14, that's meeting the definition of anemia. In women, it's less than 12. So women as a whole, they generally have lower hemoglobin levels compared to men. But everyone is an individual, right? These are just broad strokes here. So it's totally normal, you know, if a female has a hemoglobin of 14, that's actually fine. But on average, less than 14 for women, sorry, less than 12 for women, less than 14 for men. Now, I just want to make note, all these populations were largely done on Caucasians, like the standard ranges. So for African Americans, actually, they're on average slightly lower levels of hemoglobin. So probably less than about 13.7 or so for men. And for women, it goes down to about 11.7 up to the normal range. Okay, so what are risks, like when we talk about anemia, what are the risk factors once you have anemia? Why is it important? This is where I really wanted to get to. So it's been associated with poor outcomes in many different diseases. So just having anemia, you're at higher risk for cardiovascular disease, you're at higher risk for having cognitive impairment or dementia, you have a higher risk for having insomnia, impaired mood, decreased quality of life, and actually you have a higher risk, independent risk for mortality. So anemia comes along with many conditions. So a lot of times you're like, well, if I had kidney disease, and it's very common to see anemia with kidney disease, well, is the kidney disease increasing my risk, overall diminishing my lifespan? Well, they accounted for that. And when we look at studies, accounting for everything, anemia by itself has an independent risk for mortality. And we looked at patients who have cancer, who have kidney disease and heart failure, just in the elderly population. And even if you're hospitalized for whatever reason, if you have anemia and you have that condition, you're at higher risk for mortality or a higher risk of dying than if you had a higher level of hemoglobin or if you did not have anemia. So that's why it's really important. It's not something that you can just gloss over, and really diving down to why it's there and optimizing the hemoglobin level can improve outcomes. So what are some signs of anemia? So I have a picture here on the right side. You can see that, when you're anemic, you become pale, right? And there's different ways that you can see that paleness. Really, a lot of or a higher level of hemoglobin, you should be pinker in color, right? Blood is red, and you should be perfusing more oxygen throughout the body, and then generally the mucous membranes become very pink. That's the normal state. But in anemia, you have lower levels of hemoglobin, you become more pale. So we can see that in the eyelids, underneath the eyes. You can see it in the mouth and the lips and the gums. You can also see it in the nail beds and the palms of the hands. So it's for someone who has a low hemoglobin, you may not see it yourself. For example, if something's changing slowly over time, you may not recognize it for yourself, but for someone else who's looking at you, they can probably see that you look pale, or you really look different if they haven't seen you in a couple of months, and you're really looking more pale. For me, who I see people who are quite anemic all the time, sometimes just stepping into the room, I can already know, okay, someone's significantly anemic, and then I start with the questions. And we talked about some higher risks, increased risks that you have with anemia, but it's also associated with other things. So it can reduce your executive function, so your ability to think, that higher level of thinking. Physical performance is more obvious. You're really more fatigued and decreased exercise tolerance. You have higher risk for falls. That's what we've seen. More frequent hospitalizations. So in total, anemia is really a prognostic parameter, and it's a surrogate marker either for overt diseases or subclinical diseases. So it should be taken seriously. And what is not, anemia is not hereditary or genetic, largely hereditary or genetic. So these questions here, like with the myths, I would say, of anemia, I see on a regular basis. I hear from almost on a weekly basis that, well, my whole family's been anemic. Every single person on my mom's side is anemic. Well, all the females in my family are anemic, so this is normal for me. That is not true. Okay, yes, there are rare conditions that are hereditary that can lead to anemia, but these are very rare. They're very rare. And I listed some here. So rare genetic syndromes that are associated with anemia, severe thalassemia, so not just a thalassemia trait, but actually having a actual more serious thalassemia is a hereditary condition that can lead to anemia. And then there's some disorders of the actual blood cells themselves or bone marrow. What it's also not is not normal. Okay, just because you're older, or let's say if someone is 80 or 90 and, well, I'm supposed to have anemia, that's not true. That's not a normal process of aging. I see plenty of people, they're elderly and have the normal hemoglobin. It's true that it may be difficult to find the reason for anemia. Let's say we do a full workup, and I'll get to that later, and basically we cannot come up with an exact cause. That truly happens quite commonly in the elderly population, but that's still not considered a normal function of aging because you're at higher risk with that. Also, just because you're anemic doesn't mean it's because you've been bleeding somewhere, okay? Yes, chronic low-grade bleeding in the GI tract or bleeding elsewhere, chronic nosebleeds or other types of bleeding can lead to an iron deficiency, which can lead to anemia. But there are a whole list of other causes of anemia, and I'll show you a chart for that. So that's not, yes, that's a very common cause, but it's not the only cause, and we really need to be mindful when someone has a new onset anemia, well, what it could be. And then another thing that I constantly hear is, well, this person, he or she just doesn't eat right, or they don't eat well, and that's, if they just ate better, then they won't be anemic. Yes, it's true that there are some nutritional deficiencies that can cause anemia, but that, again, is a very small number on the whole list of causes of anemia. So these are very common. I hear this on a regular basis. So this is not an exhaustive list, but this is just kind of breaking down into, I would say, some very common causes of anemia. And I broke it down into how that happens. So there could be a production issue. Your body's just not producing the red blood cells. It could be that the body's actually breaking down the red blood cells. The red blood cells are being broken up in the body. Or you're losing the red blood cells by bleeding. And there's various ways that you can be losing blood. And the production issues, that's where the nutritional deficiencies, iron, B12 deficiency, come into play. I've highlighted under those, I would say, the very common causes of a production issue to cause anemia that I see. Kidney disease is it's very common in Western populations, and that commonly leads to anemia. But there's a whole other list, right? So liver disease, heart failure, alcoholism, just having, if you have cancer, there's also bone marrow syndromes of bone marrow cancers, even drugs, or having thyroid issues. Those can all lead to essentially the body's not able to produce the red blood cells, and that leads to anemia. In terms of the destruction, the red blood cells really getting broken up in the body, there are various conditions that you can develop as you get older, such as hemolytic anemia. You could have a big spleen, and the big spleen most commonly is due to liver disease. The spleen gets bigger because of back pressure in the blood flow, and then when you have more blood flow going into the spleen actually soaks up the red blood cells and essentially destroys them, and you have the lifespan of the red blood cells become less, and you become anemic. Also, sickle cell anemia is very common. That leads to it's a destruction issue of the red blood cells, and then other disorders of the red blood cell membrane. In terms of bleeding, common causes of bleeding are obviously for women, menstrual losses if you're premenopausal, any major surgical procedure if you're having major bowel surgery, C-sections, vascular surgery could lead to a significant amount of blood loss. You can become anemic. Hemorrhoids, actually, I've seen quite commonly. If you have hemorrhoids and you've been dealing with for years on end, and you have always a little bit of blood with bowel movements, that can lead to essentially an iron deficiency over time. Or just major stomach ulcers or cancers can certainly lead to bleeding causes of anemia. So anemia should be worked up. If there, one key thing from the end of, I'm hoping, of today's talk is that it should not be ignored. It needs to be worked up. Again, it could be very common issues that we find, or it could be a sinister occult reason or an issue going on, and we want to find it sooner rather than later. Many times it can be easily fixed by the simple issue, or it's something more serious. And your primary care doctor is usually the first line of defense. They do, if someone's coming and you're not feeling right, the first thing they do is a CBC largely. It's a basic blood test. It can recognize and identify anemia. And then there's some basic things that most doctors will do to kind of work that up. And then hematologists like myself, we're a specialist in the blood of benign diseases as well as cancer causes. We're there to help really tease out more complex issues. Everything is not so clear cut. You can have multiple issues going on at the same time, and then can cause a really cloudy picture, and how to tease all that out. That's our job, to figure that out. Iron deficiency. So iron deficiency is the most common cause of anemia worldwide. It disproportionately affects women of childbearing years, children, and low to middle income nations. Globally, almost 20% of all females are iron deficient and have anemia. And there are studies looking at over the age of 65, is about 12% of older people actually have iron deficiency. It's a very large economic burden if you think about it. You're tired, you're fatigued. On average, there's some studies showing on average you miss 3 work days per year. If you think about that globally, how much economic loss do we have just because of iron deficiency, which can easily be treated? And it's really under-recognized. Actually, just having iron deficiency without anemia is far more common than having iron deficiency with anemia. So many people have an iron deficiency. They're chronically living in that state. So they're just on the borderline of quickly becoming anemic. And actually in the United States, there's racial disparities in terms of iron deficiency. It's more common in Hispanic and African American populations compared to Asians or whites. There's a typical pattern, and I won't go into too much detail. My chair went down. I won't go into too much detail, but there is a very classic pattern on a CBC profile for iron deficiency. I think most doctors, everyone gets trained about this, but it's just not every pattern that looks like that is iron deficiency. So a thalassemia trait, which many people may not know that they're carrying this hereditary trait. It's not a condition, it's just a trait, you pass it on, that looks very similar to iron deficiency, but the total red blood cell count is actually elevated and not low in that situation. And you typically have a very low MCV. But these are all parameters on a CBC machine. It's basically, in iron deficiency, you have a very small size red blood cell. And under the microscope, so myself, I'm trained to look at blood smear. So we take a sample of your blood and look under the microscope to see the actual shape of your red blood cells and your white blood cells and your platelets. And there's characteristic patterns that are common with iron deficiency or B12 deficiency or some other issues. It's really caused by a low level of your iron stores in the body, which is easy blood tests to look up, right? There's a whole set standard of blood tests to do. It's very simple, straightforward, but sometimes it can be very subtle. So there's no perfect single test. There's probably the best one. If there's one test to do, there is a best test to do, but there's not a perfect test. And generally the best single test, if I'm going to look for iron deficiency, is a ferritin. Usually low levels of ferritin basically really confirm iron deficiency. And usually a ferritin level of less than 20 basically confirms iron deficiency. There's no other causes that can really cause a low ferritin. However, it's not 100% what we call sensitive. You can have ferritins as high as 200 and still be iron deficient. We call this test an acute phase reactant, so it can be elevated for other reasons. You can still have iron deficiency and still have a high ferritin and have both at the same time. If you use the strict cutoff on the labs, and when you get your blood report, you'll see the normal range for a ferritin sometimes is from 14 up to 200. But if you just use that strict cutoff, you're missing a lot of people with iron deficiency. So you have to look at the whole picture. There's some other tests we do to figure that out. We also compare that with what's going on in the history, what's going on with the CBC profile. So you have to put it really all together. It's very common in menstruating women. typically young women. You should never see iron deficiency in men. And the classic signs or symptoms of iron deficiency are chronic fatigue, feeling cold all the time, so cold insensitivity, pica, which basically means a craving to eat items that aren't normal. The most common pica symptom for iron deficiency is actually wanting to eat ice chips or ice. I have a cup of crushed ice here in this picture. If you see someone in your office, coworker, family member, first thing in the morning, they're just munching on a cup of ice and they tell you this, I just like it, or I have a craving for it, that's a very strong, basically symptom of iron deficiency. Really, nothing else should cause that craving. I've seen craving for other things too. So I've seen people who just eat cornstarch straight out of the box. Spoonfuls of cornstarch every single day. People want to eat dirt, ash, chewing on rubber bands, eating uncooked pasta, or eating paint chips. These are all pica, different forms of pica, and these are all can be seen with iron deficiency. You also see sometimes, not all the time, nail changes. So if your nails become more spoon-shaped or brittle, and restless legs is a very common symptom of iron deficiency. How do we treat iron deficiency? Generally, it's just over-the-counter iron tablets. Now, back in the day, we used to use more, we felt the higher dose of iron, the better. We would give a very high dose iron tablet, 325 milligrams of iron. Usually tend to be very harsh on the stomach. We would give it 3 times a day, every single day. But there's a study many years ago now showing that if you just give 1 iron tablet, generally over-the-counter iron tablets, anywhere from 60, 65 milligrams or so, just 1 tablet every other day with vitamin C. So vitamin C is a cofactor for iron absorption, helps you absorb iron better. But that's just as efficient as giving 3 times a day every day. And you have much less side effects of constipation that way. So there's many different brands. In my opinion, I don't really care about the brand as long as there's the dose on it. Vitron C is a brand that I commonly use just because it's 1 pill and it has the vitamin C with it. You take it, again, 1 pill every other day. It takes about, if someone is truly iron deficient, it takes about 6 months of taking the pill to really replenish the store. So it can take a long time to work. The reason for that is no matter how much high dose iron tablet you take, your body is only absorbing a very small fraction. There's a set amount, it can't absorb any more. So that's why it just takes a long time. And if you're bleeding, because iron deficiency is commonly caused by bleeding, right? It can be caused by poor absorption, but if it's caused by bleeding, then maybe your blood loss is far exceeding the rate that you can actually absorb iron, and it may never work. So that's the one downside of iron tablets. But it's cheap, it's easy, it's over the counter. Constipation is definitely an issue. So every person that goes on iron tablets should be taking a stool softener, otherwise you'll be in a world of hurt if you don't keep on top of that. But this is kind of the standard way to treat iron deficiency, is go on some iron supplements. But if the iron tablet doesn't work, what we can give in our office, and other doctors can give it too, is IV iron. So basically an iron dose through the vein. It's very quick and easy. So it's quick. You can get a full dose. Basically, we can replete your whole store of iron in a matter of a week rather than taking 6 months. It's really the fastest way to replenish stores. If someone is significantly iron deficient and significantly anemic, this is generally my preferred way to go because we want to fix the problem quickly. It's very safe. It's been well studied in pregnancy. It's safe for the fetus. It's safe for the pregnant woman. It's actually, in pregnant women, it's more difficult to raise iron levels through the tablets. You're already kind of a lot of reasons to be constipated to begin with, and you add an iron tablet on top of that, it's really going to be a problem by the time you deliver. So IV iron is one of the, actually, iron deficiency in pregnancy is one of the most common referrals I get for IV iron. There are potential side effects with that. The most serious is this risk of anaphylaxis, or like a severe allergic reaction. It used to be more common in the old formulations. So that's where if you talk to people back in the day who received it, they worry about this, but it's not common anymore with the newer formulations. It's really, one study showed it was about 1 in 250,000 doses. So it's very unlikely. I've seen it once in my last 5 years. So it can happen, but it's really unlikely to happen. Other side effects, you can have a headache. You may have some diarrhea. That's actually rare. Or you can have a little bit of rash. The main issue is that it's expensive. So many insurances, you have to prove that you either cannot tolerate oral iron or the iron tablets are not working before they would approve the IV iron. So many insurances that can be the case. There are many formulations. I've highlighted the one that we typically use. It's called ferric carboxymaltose or Injectafer. Basically, it's just 2 doses, 1 week apart. It takes about 45 minutes to get the dose, and you're done. We also have a coupon program. So, you know, for if you have a copay that's extremely high, it could be a couple $100 sometimes for each dose. With that, most people we can get a $50 copay coupon essentially. You just pay $50 for a dose rather than paying $500 per dose. So we like to use that. It actually has low rates of infusion reactions and very well tolerated. It actually has the data in pregnant women and the data and the use in heart failure. So we like to use that. But really, you could use any one if you had to. One is not necessarily better than the other. You generally, after a dose of IV iron, you feel better within a couple of days. You have a better sense of well-being and energy, but it takes a couple of weeks for the blood counts to really normalize. Much faster than oral iron. For postmenopausal women and for any man with iron deficiency, you must get a GI evaluation. The main concern there is that we do not want to miss out on a potential cancer in the GI tract. So that goes along with that. You're going to treat the iron deficiency, but you need to get a GI evaluation, whether it's upper and lower or both endoscopies, but you need a GI evaluation if you're a postmenopausal woman or for any man with iron deficiency. Okay, just moving along, I see that we're already at 12:30. B12 deficiency. So there is a typical pattern for B12 deficiency on a CBC. There's also characteristic pattern in a blood smear. It's caused by low levels of B12 or a functional deficiency in B12. You can easily check a B12 level in the blood. Sometimes it can be a little bit tricky to diagnose. A level less than 200 is diagnostic. You don't need to do anything else. You have low B12. If you're between 200 and 300, there's another blood test that we do. I listed the blood test here. It's actually quite common in older people. It's about anywhere from 2 to 11% over the age of 65. How do you get B12 deficiency? Well, you could just have poor intake, and that's usually in the form of veganism. Because B12 is in meats, dairy products, your body has about 2 to 4 years of storage of B12 in the liver. So if you choose to become vegan, then it takes about 2 to 4 years before you can become deficient if you're not supplementing. Also, it's commonly seen in alcoholism. You can have just poor absorption in various diseases. So celiac disease, Crohn's disease, basically inflammatory bowel disease. There's other conditions in the stomach. Atrophic gastritis is one of those. Pernicious anemia is where you have an antibody that loses this particular cells in the stomach that helps you absorb the B12. You lose those cells. Or if you have bariatric or stomach surgery. Also tapeworm, but that's not common in this country. Medications can also lead to B12 deficiency by poor absorption or poor metabolism. So metformin actually is more recently recognized that it can lead to B12 deficiency. Chronic use of what we call proton pump inhibitors. These are medications for acid reflux. The strong medications like Nexium, Prilosec, pantoprazole is one. I've seen people who are on these for years, like a decade, that then become iron deficient, and that's just from chronic poor absorption of iron deficiency, as well as it can lead to B12 deficiency. And then there's some other medications, methotrexate and sulfasalazine, they use in different autoimmune disorders. Classic symptoms, fatigue, okay, forgetfulness. So these are more neurologic symptoms: forgetfulness, numbness in the fingers, hands and feet, unsteady gait, balance issues. You tend to see a kind of a flat tongue, a very smooth, shiny tongue. Actually, severe B12 deficiency can lead to psychosis. So it's part of a workup for someone who has, one, psychosis or really dementia, confusion, to check a B12 level. How do we treat it? Oral tablets. So that's very simple and easy. If someone has a condition where you're not able to absorb the B12, like in pernicious anemia, taking high-dose tablets actually can overcome that decreased ability to absorb. And generally, we recommend a dose of 2,000 micrograms or more. Or you can use the monthly injections in the arm. The response to the B12 supplementation should be very quick, much faster than iron deficiency. You see essentially a response in the blood work in a matter of days. So there are times when you're not quite sure. It's very cheap and easy and low risk to give B12 supplements and see if that's going to fix the anemia. It's more an empiric way to do it, but because you can see a response very quickly and there's virtually no risk by taking a B12 supplement, it's very easy to do sometimes. The duration of therapy depends on the cause. So if you're a vegan and you're just not taking the supplements, you just need to supplement for a couple of weeks or even a couple of months and you should be fine. But if it's a chronic issue with absorption, you may need to be on it lifelong. Now, the key thing with pernicious anemia or atrophic gastritis, so basically you're losing the cells to help you absorb B12 in the stomach, you should actually, the recommendations are to see a GI doctor to screen for cancers in the stomach because you're at actually higher risk for getting cancers in the stomach with B12 deficiency related to that. So atrophic gastritis or pernicious anemia. Oh, and then the last topic is just anemia in the elderly. So, it's very common to see anemia in the elderly. It's not normal, okay? And a lot of the times we do a full workup and we don't have an obvious cause. Okay, so this is not a normal condition. There are various causes that are, I would say, more subtle to figure out. So one condition is a low-grade bone marrow disorder. We can call it a bone marrow cancer. It used to be called pre-leukemia. Now we call it MDS or myelodysplastic syndrome. The only way to really diagnose that is with a bone marrow biopsy. So a lot of times I'm in that situation where, well, we're someone who's older, we have anemia, all the blood work doesn't come up with an obvious cause, and now we're looking at a point where do we need to do a bone marrow to rule this out? And it all depends on the situation. How quickly is this developing? How low is the hemoglobin? How severe is the anemia? What's the, comorbidities, expected lifespan? We want to go through a bone marrow biopsy to rule this out because it is an invasive procedure. So it's a common discussion that I have with people, and a lot of times I do it, especially if I see some other concerning features, and that's where a blood smear, looking at the blood smear, can be helpful. I would say recently there was someone who wasn't that old, but she was close to 60, and she just had anemia. But there was something that wasn't right on the bone marrow. I saw a funny cell, ended up doing a biopsy, and there was leukemia. So and the blood work also was totally fine. All she had was anemia. It was just actually not that bad of a mild anemia. But there was a funny cell in the blood smear that wasn't picked up in any machine or test or anything. So that's why it is helpful. It's important that a hematologist looks at the blood smear because you can pick up subtle things. But anemia in the elderly, there's this thought of something called inflammaging. So aging and inflammatory and basically chronic inflammation as part of aging. We know that chronic inflammation can lead to anemia. Right? There's chronic inflammatory conditions like rheumatoid arthritis, lupus, rheumatologic conditions that can lead to anemia. And we don't know a lot of information now, but we know that general inflammation can occur through different processes as we get older, and that likely can lead to anemia. I listed here, there is a condition where you can have, let's say we do a bone marrow and we find abnormal mutations that we commonly see in these conditions like MDS or leukemia, but there's no evidence of MDS or leukemia, but we pick up these mutations, and it is thought to be that maybe there's some mutations that are related to low blood counts or anemia, but we don't know what it means beyond that. Most people in that condition will not progress to MDS or leukemia. Actually, the vast majority do not, but that's one potential. And that condition is called CCUS or CCUS. If you've heard of MGUS, it's like the MGUS variant in anemia called CCUS. It's actually quite common in elderly. It's almost up to 36% of people who are anemic in the elderly, and we don't know any other cause. It could be this, but actually a very small percentage actually progress. So for most people, if the anemia is mild and we do the workup to rule out other causes, it is actually quite safe. And most of the time I do this, I will just monitor closely. It's unlikely to cause a major issue, but it's good that we monitor it because we want to make sure that nothing's clearly getting worse. And that's whether or not we end up needing to do a bone marrow biopsy or not. But I'll end there. So just a couple take-home points: that anemia is not normal. It needs to be pursued. It could be quite complex into various factors contributing to the anemia. Iron deficiency is the #1 cause of anemia worldwide. It's underdiagnosed. It's quite common and easily treatable. Look out for family members, coworkers for those signs of iron deficiency, especially the compulsive eating of ice. B12 deficiency is also quite common and easily treatable. And optimizing anemia can lead to improved outcomes with reduced overall mortality and increased quality of life. And that's why it's important to identify it and to optimize it. And that is it. And I'll take questions.
All right, great. So I think you're gonna get a lot of questions about pica.
Okay.
First one is, why do they want to eat these odd things if they have pica?
Yeah, we don't know. No one has been able to figure that out. Even with all, we don't know why there's that connection. There's a lot of hypotheses. You know, a lot of the pica is like crunching on hard things, right? So the uncooked pasta, ice, paint chips, but we don't know why. It is a mystery at this point. But if you start noticing it, it's quite common. And when I ask some people, "Are you eating ice?" And they get taken aback because it's like their little secret, that they do it and they don't know why. It's like every morning they have to get that cup of ice before they get to work, or right when they get into work, or before they get into the car, and they don't know why. So if you start asking people, you'll see it's quite common.
And then does it correlate? Does the level of the anemia correlate with the amount of ice or pica eating? I mean,
not in my experience, and I don't think that's been shown in the data. But the level of, you don't tend to see the people that I see the ice, they're really iron deficient, but the level of anemia doesn't necessarily correlate with that. If you have a mild iron deficiency, I would say you're less likely to have the pica. So it definitely correlates more with the degree of iron deficiency, but not with the degree of anemia.
Okay. And then if people are listening, if you guys want to submit some questions, we have some time. So here's another one. And this is particular to a certain patient. I don't know, the female patient, I don't know how old, but she said she has been borderline anemic for the majority of her life. Is this common or a problem? And then she followed up with a little bit of information. Her average hemoglobin is about 10.2 to 10.4.
Mm-hmm.
And I think that's all we have so far. So what would you advise this patient to do?
Yeah, so it all depends on, how long has this been going on and what blood work has been done about that. So, the age of the patient, we need to know a lot more information, but I would say start with a basic workup. If the primary care has done looking at iron levels, B12 levels, depending on how old the patient is, if they're premenopausal, then it's much more likely to have something related to potentially iron deficiency, depending on the blood work. If they're older, they have other comorbidities, could it be related to kidney issues? So there's a whole slew that we do of testing and workup. So it all depends. And if really not getting anywhere, then, have them referred to a hematologist to really figure that out. But I would say, mild, it sounds like it's pretty mild, but that whole list of causes of anemia come up. So I would say you need to kind of do some more workup.
Okay. Yeah, so I think a lot of the questions we get might be kind of sort of specific. So here's another one. If you've done an evaluation with a hematologist previously and it was determined that I am just low normal and my primary care keeps an eye on the numbers and we do not treat, do you have any thoughts on that?
Yeah, so if you've been seen by hematologists, and it would all depend on kind of the workup, but if everything's coming back negative and they're quote unquote low normal, everyone, the ranges are generally a range of like 95% of the population fit in that range. So there are some, some people who have a lower normal, let's say a lower level of what's normal for them. But a lot of times that particular situation, there could be potentially a thalassemia trait, right? That's something that you have to do a special test to look up for thalassemia. And there's actually one thalassemia, such as alpha thal trait, that comes up as quote unquote normal on your standard test for looking up thalassemia. So you can only find that with a genetic test. So a lot of times there's likely something else there. And thalassemia trait is nothing that you need to worry about, right? It's just coming to the cause, and it doesn't cause any problem. A lot of times I also see mild anemia if there's, like, let's say a mild underlying autoimmune or inflammatory condition that you can't really pick or diagnose yet. That's commonly there too. Now, whether or not you need to do something about that all depends on the situation, how the person is doing, how they're feeling, how long this has been going on for. If it's really not changing in any degree, then it can certainly be monitored for a long time. But in general, being anemic is not normal. There's a cause there that you just have to figure out,
Okay. So here's one. What do you recommend for a 63-year-old woman with arthritis who has anemia and perfect blood work, no deficiencies? I had norovirus for 3 weeks with severe dehydration, but well for over 4 weeks now.
Mm-hmm. So it would be, I would want to know what's the degree of anemia. Is the arthritis rheumatoid arthritis, or which is the more autoimmune type arthritis, or osteoarthritis, which is wear and tear arthritis? And it depends what blood work we do. So yeah, anemia is very much a detective work, right? You have to be a detective and kind of get a full history and really piece together before I can just start recommending tests to do, right? I have to look at the full information. But what I would want to do is look at the blood smear, look at the whole CBC profile, and see what tests were done to see if we need to do anything else. It's very common to be transiently anemic in the setting of an infection. Okay? So it's very common once someone's sick enough to go into the hospital to become anemic from all the blood draws, and we're giving a whole slew of medications, and you're getting pumped with fluids, and just the inflammation and infection can lead to anemia. So it takes several months even to recover from that. So that's also one possibility. It's very common. I wouldn't think norovirus itself would be a classic one that's associated with anemia. So all the details are important here, right? All the nuances are important.
And she did further clarify it's osteoarthritis, although it sounds like you still need probably more to that story.
Yeah, so osteoarthritis is not commonly associated with, let's say, quote unquote, chronic inflammatory disease that's related to an anemia. So that's not something that would commonly associate with anemia. So it really kind of depends on, right, the details. What workup has been done. Want to make sure that we look at the blood smear and really see if there's any other conditions or just chronic inflammation going on, right? That can also be the case.
Okay. And then I get a lot of questions about bone marrow biopsies these days, because I know they've become a little bit better than they used to be. Can you just describe what that process is?
Yeah, a bone marrow biopsy is a minor procedure that we commonly do in our office. So it's essentially taking a needle and sampling the bone marrow through the lower pelvis. So I'll stand up and show, if you can see, kind of, we kind of find where your pelvic bone is closest to your skin on your back, right about here. And all there is skin, fat, and bone. It goes right to your pelvic kind of bone. And we use a needle, we numb using lidocaine. So we numb the skin, we numb kind of the tissue all the way down to the bone, and we numb the outside of the bone. And then we take a needle, bigger needle, we go through, and we poke through the bone. And then we suck out some bone marrow, which looks just like blood. Looks like just liquid blood. And then we take a piece of the bone on the way out. So and we put a little Band-Aid on. So it's a minor procedure, right? We're not making big incisions. It's not a surgical procedure. The issue comes, though, is that I can do a really good job numbing the skin down to the bone, where you just feel pressure during the whole process. But what I can't numb up is the inside of the bone. So there's a couple second period where we're actually sucking out some of the bone marrow, where you may hear stories that it's very painful or discomfort. And I would say it's not 100% of the time, but there is a chance of discomfort. But it's usually just a couple second period of time, like a 3-second period of time where there's some discomfort. And we kind of warn you it's happening, it's going to happen, and it's usually quick. start to finish is about 20 minutes, and it gives us a lot of information. So if someone is recommending you need to do a bone marrow, that's usually because it's something serious, right? We're either worried about something we're very serious in the bone marrow, or really want to make sure or rule something out. So if someone is recommending that, I would really think about doing it. But in general, it's a minor procedure. There's a chance of a small period of discomfort, but there's no long-lasting discomfort, and it's really just a little Band-Aid that you have at the end of it, on your back.
Yeah, and that used to be a much more invasive procedure, correct?
Well, I think where a lot of the stories come from is for people who do it, let's say, not gently and properly, it could be quite traumatic, right? Someone's poking you with a needle, and you're just using local lidocaine. For some people, it could be quite traumatic, especially, if someone's not doing it properly. The procedure itself has been the same way that we do it for the last 30 years. But it's how you're trained, taking enough time to allow the lidocaine to work, really numbing the outside of the bone. For me, I take my time, and I know that that's where all there's a lot of nerves involved, and that's where the discomfort can happen. So I really want to minimize all the discomfort I can. And then there's only that little short period of time where there could be discomfort. And to be honest, not everyone feels it, and it's about 50-50. In my experience, I've done hundreds of these. It's about 50-50 for someone feeling no pain whatsoever. So it's not a guarantee. It's not a guarantee.
Okay, well, these are all the formal questions that we have. If anyone has any last-minute questions, submit them now, or I guess forever hold your peace. But let me just quickly go over the announcements. So as I said at the beginning, if you guys missed it, well, Friday, the office is closed because it's 4th of July weekend, so we are closed for the holiday. And then next week, we're going to take a hiatus from the webinars, and then we may bring them back on a limited, possible once a week or once a month basis, depending on what's going on with COVID, because we are moving back towards opening the office a little bit, and that'll take away from the ability to sort of devote resources to this. And despite seeing my face, there's a large team of people on this project who might need to sort of divert their attention elsewhere. But so stay tuned for email with a formal update. I'm not sure exactly when that will go out, either this week or next week. Thank you to everyone who's been tuning in. Thank you especially to our speaker today, Dr. Mahmood, who gave a wonderful talk on anemia. Anemia is a very complicated analytical sort of medical issue. So if there were things today that you were confused about, or if you're concerned about yourself, definitely talk to your primary care doctor as a first start. And then if needed, you would be referred to a hematologist. But any last comments you want to make before we end the session? Anything else you want to make a plug for here?
Oh, yeah, just, we recently, I joined the practice in August, and we recently opened an office in Germantown. That was the whole reason why I was hired. And we just got started, we're up and running, and then COVID happened. So we actually had to close down the office, but we're back open. It's in Germantown on Seneca Meadows Parkway. I'm here right now. And we just reopened for the past 2 weeks. So we're kind of a local resource. Really, I'm here to serve the more Germantown community. I'm here 4 days a week, but I also go to Rockville. So that's the only thing I would say. Just think about we're trying to have a better increased presence in the county. That's about it. And thank you.
Thank you. And thank you to everyone. You guys have been saying in comments that these webinars have been very nice. So thank you. I do appreciate that, because I do spend a lot of time trying to pull this together. So I will try to get these together, but as you guys know, with the office opening, and then I think many of you guys know I'll be out on maternity leave starting mid-August. So that also limits some of the ability to continue these, as much as I hate to admit that. It does, just because I'm the one who is probably the most excited about these webinars. So so thank you to everyone who's been listening. Thank you to Dr. Mahmood and all of our other speakers who are not here right now, but in case you guys see any of our specialists in the office and you had you saw the webinar, feel free to say, hey, I saw your webinar and it was great. And then right before we wrapped up, somebody just at the nick of time put a question here. Oh gosh, this could be a whole fellowship. Question is there a treatment for chemotherapy associated anemia?
Yeah, so I would say it's not a simple answer, but in general, yes. So there is I call it a blood booster shot, Epogen, or some of the classification of erythropoietin stimulating agents. So it's a shot that you can get to try to help boost up the red blood cells during chemo. Now there's nuances there. You don't want to necessarily get to every single person who gets chemo because we really don't like to use that in the setting of curable conditions. So if you're getting chemo in a curative state where you're trying to cure someone of the disease, so you may not want to give that shot in that situation. There's some minor risks there that you would have to talk about. But that's the best medicine that we have. Sometimes IV iron can help, right? If it's cancer can lead to inflammation and basically poor utilization of iron. And in that setting, IV iron can help too. So there are things you can do to try to help improve the anemia that the chemo is actually pushing down. But it's not so easy. A lot of times you just give blood transfusions to help support through that. That's probably the most common thing we do. Or lower the dose of chemo. So it is a tough situation. There are some things you can do. And if you're in that situation, then definitely talk to your oncologist about how else could you manage or how can we optimize the anemia related to chemotherapy? Because those are the things you could do. You give blood transfusions, you could give or just a dose of the chemo, or give IV iron or this blood booster shot.
Okay. All right. Well, there you go. The last nick of time question, complicated. So, so thank you everyone for tuning in. Have a wonderful Wednesday and a wonderful 4th of July weekend. Thank you to Dr. Mahmood for coming in and giving us a wonderful talk. As you guys know, it's recorded, and if you wanted to go back and listen to something, they're usually posted to our website on a few days delay. So tune in if there's something. You can always rewind and watch a little part. But thank you and have a wonderful Wednesday.
Thank you, everybody. Thank you. And congratulations, Dr. Tanno.
Oh, thank you.